Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center in New York City. What is the likelihood that pulmonary nodules are malignant in cancer survivors? Cancer survivorship has increased over the last 30 years. The population of cancer survivors in the United States is currently 17 million, which is approximately 5% of the total population, and is projected to exceed 21 million by 2029. The current number of cancer survivors in Europe is unknown due to heterogeneity of cancer registries across countries. However, there are more than 3 million new cases of cancer diagnosed in Europe each year, with approximately half of the patients surviving for 10 years or more. Therefore, cancer survivorship is a growing public health issue. It has been estimated that cancer survivors have a 14% higher risk of developing a second primary malignancy than the general population, with lung cancer being the most common diagnosis. Lung cancer occurring as a second primary malignancy represents 8 to 14% of all lung cancer diagnoses, and the diagnosis of lung cancer is frequently the primary driver of future life expectancy. Data from the lung cancer screening trials have provided evidence that low-dose CT can reduce lung cancer mortality. Notably, the NLST trial, which stands for the National Lung Screening Trial in the United States, demonstrated a 20% relative reduction in lung cancer deaths in individuals 55 to 74 years old with a smoking history of at least 30-pack years. And also the Nelson trial, which was the Dutch-Belgian randomized lung cancer screening trial, demonstrated a 26% reduction in lung cancer deaths at 10 years following follow-up in high risk of asymptomatic patients who underwent screening. These findings have led to more national and international professional associations recommending low-dose screening for lung cancer. Now, it's important for us to differentiate who we're looking for. So let's say, categorize high-risk smokers from non-smokers. Or we may need to characterize patients that have known metastatic disease versus those that have no evidence of current disease after being treated for a cancer. So clearly, if they already have known metastatic disease, the likelihood of a nodule being another metastatic lesion is higher. Specifically, it's important to also know what type of tumor those individuals have as a primary tumor, because certain lesions preferentially will go to lung while others may not. We also need to look at additional risk factors, which include occupational exposure to carcinogens and smoking-related cancers. So in recognition of this potential increased risk in patients, NCCN, which stands for the National Cancer Comprehensive Network, has looked at screening guidelines for lung cancer, and I'll share the screen with you. So the group 1 is the smokers, but if you look at group 2, which is 50-year-old individuals or older with at least a 20-pack year history, they've included one additional risk factor that could put them in this group. And one of those risk factors is just the history of a smoking-related cancer. So that could be something like a head and neck cancer or a bladder cancer. Other additional risk factors per NCCN for having a lung cancer would be history of thoracic radiation. That certainly increases the risk, and it's dose-related. The risk for a radiation-induced cancer begins approximately 2 decades after exposure. Chemotherapy agents, specifically the alkylating agents used in Hodgkin lymphoma population, can also be an additional risk factor. And concurrent radiotherapy, in addition to the chemo, is an additive factor. So those are important things to know. Of note, some previous studies have found that the incidence of a second primary lung cancer in survivors of certain cancers is higher than, for example, they use the control in the NLST trial, suggesting that these populations may benefit for inclusion in lung screening.